The next speaker is John Marini. Doesn't need any introduction, since he had an introduction already, or else he might have needed an introduction. No, he doesn't need an introduction. And he'll talk to us about the impact of the microvasculature in ventilator-induced lung injury, something that isn't often thought about, but probably relatively important. John.
Thanks very much, Art. I'd like to add my thanks to McKay for organizing such a nice symposium. There doesn't seem to be any of these that I've attended that I haven't learned a lot from, and this is true also of this morning's and this early afternoon's presentation so far. I hope with this talk I will begin to open your eyes not only to the vasculature, but to what I would have to say is demand-side economics. And I'll explain what I mean by that in the end. But just to give you a glimpse, everything we've been talking about is related to what doctors do to patients. If we can reduce the demands of the patient on what the doctors need to do, we may make the most instrumental change of all in a complex environment. That's the main message. But let's talk now about the microvasculature. In this talk, there are really two principles, as I can define them. And the first is diversity, and the second is complexity. As currently defined, ALI and ARDS is a diverse set of problems that defies simplified approaches to therapy. I commented on this morning. And I think that evidence-based medicine, while instrumental in some cases, will not give us the full prescription for what we need to do at the bedside. That's because our patients are also complex, and the importance of pathogenetic cofactors and therapeutic interventions for ventilator-induced lung injury is conditional on the degree of tissue strain. When the lung is under high strain conditions, a number of cofactors influence its susceptibility to damage. And one of those is vascular pressure. Key principles of lung protection: the risk for ventilator-induced lung injury is proportional to not just plateau pressure or PEEP, but to their transalveolar pressure equivalents in any given individual. And we don't measure what's outside the lung. Lung recruitment is essential to avoid ventilator lung injury when, and perhaps only when, high inflation pressures are used. A third, when tissue strain is high enough, modifiable cofactors may be important in ventilator-induced lung injury expression and prevention. And I think we have examples of this in the literature and from experimental work regarding position, minute ventilation, and temperature, as well as what I'll address, which is vascular pressure. Earlier, we talked today about the amplified forces that occur at the junction of open and closed lung tissue. And I'm not going to bore you with going over that again, but I am going to remind you that the whole process of ventilator-induced lung injury may be comprised of several different types of injury, and they can be confusing when we don't specify what we're talking about. In the open lung, we stretch it. And if we do that with enough intensity and enough repetition and severity, we may inflict inflammation. At the junction of open and closed lung tissues, the amplified forces that Gary talked about this morning and that we're trying to avoid are greatly intensified. And for some of us, avoidance of those shearing forces is instrumental. And the third thing seldom talked about is airway, micro airway trauma. The trauma that occurs at the junctions of closed airways with their alveolar portal. They're unsupported, and they may undergo damage just as the delicate alveolar tissues do. When we talk about the vasculature and talk about the relaxed lung and the stretched lung, you know that I think that the capillaries and the interstitial microvessels do quite different things. Expansion of the lung causes capillaries that are embedded in fully open lung to collapse, and actually they may even be protected, as John West has suggested, under those circumstances. But the microvessels that are in the interstitial compartment are stretched by powerful forces during lung inflation, and these may be the vessels that are most at risk for damage. This from Luciano Gattinoni basically points out that when we look at a CT scan and see the heart in the two... Yes?
That group can't see, well, that's I can't see.
Okay.
So can you just, if you do this, you get the arrow.
Oh, okay. Luciano and others have pointed out that the lung is heterogeneously affected mechanically. You have some areas that are consolidated, at least in the advanced stages of ARDS, and cannot be opened by any pressure or any recruitment strategy. You have other lung regions that are collapsed, and there is gas reabsorption so that the pressures that are required to open them are very high, in the range that Fernando talked about, 60 centimeters or more. Perhaps the majority of collapsible tissue, especially in the early phase, however, is in these small airways, which take only 10 to 20 centimeters of water pressure to open. And then, of course, in the non-dependent regions, there may be some lung units that are continuously open and don't need any opening forces at all. If you're looking at a real example, you would anticipate that the zone at the very base down here might not be susceptible to airway pressure injury at all, because there is no airway pressure that it's exposed to. Those lung units that are out of commission may be protected. If they're flooded, they may be out of commission and not susceptible to the same forces. The end show? No, I don't think so. Let's see. The zone of risk, if we're thinking about the shearing forces, are probably the tissues at the interface of closed and open lung units. Now, this example I use virtually every time I talk about this topic, and it was so impressive to me 13, 14 years ago when it was generated that I think I should share it with you, because it started with a large animal being ventilated at high inflation pressures and low levels of PEEP. If stretch were the issue, the non-dependent zones would be the ones that should be severely damaged, but they're not grossly and they're not microscopically. The areas that are really affected are those at the very base of the lung and almost going up in a sequential fashion you can envision over the course of the experiment, so that there is really a sharp junction between the injured and the non-injured tissue, and it is in the dependent area. In this healthy animal injured by purely mechanical forces, I think it's a good argument that we need to pay attention to what's happening at the junction of closed and open lung units. Stretch may be important, and over time may be very important, but over the course of the 6 hours that this experiment took, it was the dependent zones. In this summary of what happens when you have closed and open lung units together, if you start in this position with the grays being the closed and the white-rimmed areas being the open, if you apply moderate stress and strain, you may indeed initiate a signaling pathway that leads to cellular infiltration and inflammation. If you put very high stresses on the lung, on the other hand, you may in fact rip the lung, wound the lung, tear the lung, that then calls forth an inflammatory response. And when you look at the end product, you may wonder which of these you're dealing with. You can talk about the first one I mentioned as the two-hit pathway, because when a lung is susceptible to injury, then the ante goes up. More modest pressures are possible inflictors of injury. When we deal with very high inflation pressures and low levels of PEEP, we may generate wounds in the lung. And so I think we're talking about several different kinds of mechanisms. I like mentioning this paper. It's one of several that have come from the University of Michigan, and Ron Herschel is the senior author on these, that pointed out several important things. Not only is the end inflation tension important and the end deflation tension important, but so is the flow rate and the extent of the inspiratory time to which that lung is exposed to those pressures. What you're looking at here is low pressure control lungs and their histologic equivalents, high pressure normal rate, and you see a damaged lung with a lot of bleeding in the tissue. I'm going to come back to that as we go along. In the third situation, you're looking at the same high pressure and normal at a lower rate and a 6-second duration of the inflation cycle. In other words, a prolonged stretch. Going down further, high pressure, low rate again, this time reaching the same pressure only for 2 seconds instead of 6, suggesting that stretch is indeed important, even at the same targeted pressure. And finally, and probably most interesting to me, is that when you reach the same high pressure and do it over 6 seconds, but do it slowly, don't have a rapid DP/DT, you don't get hemorrhage and you get much less histological change. And this was shown in a couple of different large animal studies that they've done. So we are certainly not all the way there in terms of understanding what parts of the ventilatory prescription are important. Tidal volume, tidal pressure, PEEP, yes, but also probably frequency, probably also extent of inspiratory end inspiratory pause time, and the rate at which the pressures are generated. So the potential mechanisms for edema are many. What about the hemorrhagic edema? The hemorrhagic edema could be the two-hit tissue inflammation and disruption, or it could be inflammation after disruption has already occurred. Which is it? Well, the interstitial vessels that I mentioned before, when you go from an alveolar pressure of 0 to, say, an alveolar pressure of 30, it's been calculated, and this is from a paper that Marcelo and I wrote together, that the interstitial pressure may be as low as minus 56 centimeters of water surrounding those microvessels. Whereas under the relaxed state, the interstitial pressure is only a minus 10. The transmural pressure here is 10. The transmural pressure here is 86 centimeters of water. So we need to consider what's flowing through the lung in terms of when we talk about ventilator-induced lung injury expression. John West and his colleagues have made many beautiful studies looking at the effect of vascular pressure in static lungs and shown that you can tear the capillaries with enough transmural vascular pressure. And it varies from species to species. For a large animal, it may be like 95 millimeters of mercury for a dog. For a rabbit, it may be 40 or 45 millimeters of mercury to produce such changes. This is in a lung that's not being ventilated. I'll show you that when you use a experimental preparation such as this, which is an isolated, ventilated, perfused lung model, which is being continuously weighed and perfused with controllable flows or pressure, and ventilated with the same ventilatory pattern time after time, you can generate tissue hemorrhage. This is from one of our studies. John Hotchkiss was the first author on this particular one. what we did here was looked at hemorrhage score, and in the 3 categories across the bottom were varying frequency and precapillary vascular pressure. Now I remind you that we're dealing with the same airway pressures the whole time. The same airway pressures, same ventilation pattern. What you find is that when you ventilate with a frequency of 20 and a precapillary pressure of 20, you have very little hemorrhage to be detected. When you ventilate with a frequency of 20 and increase the microvascular pressure to 35 millimeters of mercury, at least in this model, you get a tremendous amount of hemorrhage. What's particularly interesting is that if you keep microvascular pressure high at 35, but reduce the frequency with which the lung is ventilated, keeping inspiratory time fraction the same, so the mean pressure and the peak vascular pressures are the same, the only real thing you're changing is the frequency with which this is done. You get considerably less hemorrhage, suggesting that frequency is an important parameter as well. Why is low frequency protective? Well, one of the issues that has been brought up by others is that hypercapnia attenuates ventilator-induced lung injury. Indeed, Alain Brocard, who works with me now, did this experiment where looking at both protein in bronchoalveolar lavage fluid and hemoglobin in the bronchoalveolar lavage fluid favored hypercapnia in reducing those manifestations of ventilator-induced lung injury. But we've repeated these experiments with tracheal gas insufflation to keep PaCO2 okay, and we get similar results. There's something about the mechanics going on here. This is eukapnic ventilator-induced lung injury from Sinclair and colleagues. Same conditions, but under hypercapnia, actually protected the animals in this experiment. So getting back to this graph again, could it be that when we ventilate at a normal frequency, we don't allow the lung to recover between these stressful cycles? Actually, this is kind of amazing the first time you hear about it, but you can actually damage the lung and then see it repair in a very short period of time. To my knowledge, the first to show this to us was Didier Dreyfus using radio-labeled albumin. And basically what he showed is within 5 minutes of a few stretch cycles that were under high pressure, within 5 minutes you were back down to the same edema and manifestations of leakage. Brilliant work. I don't call Dr. Hubmeier brilliant very often, but I'll say it this time. Brilliant work from his laboratory by Gajic and colleagues showed that if you apply a label that is important in that it is excluded from healthy cells, but damaged cells will admit the label. If you apply the label during the ventilation process, you see it inside, and you see cell death occurring. If you do the same ventilation and stop and wait, and then apply the label, you do not see it, suggesting that some repair of some micro fractures has occurred. Now, I certainly can understand how moderate stress and strain can respond like that. I doubt that the ruptures that I'm going to show you could be repaired that quickly. We're more inclined to think that when frequency goes up and you have the lung under stress and you have the precapillary pressures that are high, then cumulative damage may be very important. There are other explanations, but cumulative damage, again and again and again hitting the lung is trouble. And in the interest of time, I'll go very quickly, but basically, if you look at edema formation, for the first 10 minutes of this experiment, basically it's indistinguishable whether you're ventilating at a frequency of 20 or a frequency of 5. But something happens right around the 18th to 20th minute where there's a tearaway exponential equation, like the lung has broken down, the dam has opened, and the lungs are flooding. it's almost as if enough cycles have gone by to rip things open. And this is only over about a 4-minute period of time. Admittedly, it's a ex vivo lung, and there are a lot of things that could be criticized by that kind of experimental approach. But one possible explanation for these findings is that when you have high tension stress points, such as at the junction of open and closed lung units, you can eventually snap the structural elements, very much like you take a fragile material like a paperclip, and as we've all done, bend it the wrong way enough time, and the highest stress point eventually gives way. When it does that, it throws the load on other structural elements, and Gary alluded to this morning when he showed us his nice videos and cartoons. In the USA, you'll probably remember about 3 years ago, we had a massive rolling blackout, and it was attributed to one of the contributing centers to the power grid breaking down. And in so doing, that breakdown through a load, which all of the power stations were contributing to, threw it into a mode where the others had to pick up the slack, and then the next weakest ones started to drop out of the system, and eventually you were left with a rolling process that caused extensive woe, and in the setting of ventilator-induced lung injury, perhaps it's just the final break that occurs once you get this process underway. Progressive loading of the system, cumulative damage due to too high a frequency a minute ventilation requirement. Now, in just the last little bit, I'd like to talk about the other elements of the vascular pressures. The precapillary pressure we talked about going up causes the same airway pressure profile to cause trouble. Again, Dr. Brocard and his colleagues have shown that if we keep the precapillary pressure the same and drop the postcapillary pressure, we get into trouble, which it sounds counterintuitive when you first hear about it. How could it be that if you drop the left atrial pressure, the pulmonary venous pressure, that you're going to get more edema and trouble? These are the data. Again, looking at the situation where alveolar pressure is 20 and 25, nothing seems to be much amiss, whether in terms of edema or permeability. It's when the lung is under stress that, in this case, the high pressure with low pulmonary venous vascular pressure caused increased edema and permeability. Again, interesting data. Potential mechanisms to explain it. You might think you're intermittently causing zone 2 conditions, and that accentuates vascular interdependence, causes energy to dissipate in the waterfall that you create across the lung, and that you get endothelial shearing forces occurring because of the high velocity of blood flow through those zone 2 regions. Again, not necessarily in the most dependent area, but at the interface between open and closed lung units. It's an intriguing possibility. These are zone 3 conditions, where the capillaries remain open throughout the respiratory cycle. Zone 2 conditions intermittently show some collapse of the capillaries, some capillaries more than others. So I've been trying to show to you that when mechanical stresses are sufficiently high, vascular dynamics have the potential to modulate ventilator-induced lung injury. Raising precapillary pressure or reducing postcapillary pressure may increase ventilator-induced lung injury, and increased respiratory frequency and or minute ventilation, both which were increased in our experiment, may worsen ventilator-induced lung injury. The implication of all of this, what is consistent with all of this in terms of a potential for exploration for recommendation, is that if we reduce minute ventilation and cardiac output, it might help the patient. Reducing oxygen demand and ventilation targets may lower the risk for ventilator-induced lung injury. And this is the message I really want to leave with you guys. We've recently heard that a fluid conservative strategy is well tolerated and gets patients off ventilators earlier than a more liberal fluid administration strategy. Whether this has any tie-in with our experimental data, I'll leave it to your judgment and analysis. These are just some of the electron imagery that supports the data that I've just given to you. These are perfusion fixed rabbit lungs that are normal, and you can see the capillaries being pointed out in the arrows that are shown. This is from our laboratory, and what you see is a blood vessel, a small blood vessel, surrounded by red blood cells, which should not be there. They should be inside a blood vessel perhaps, but not in the perivascular area. There has been a rip, a tear, a communication. Other pieces look like this, with highly non-anatomical structures that show that there's the possibility not just for mediators, which I am sure leak into the bloodstream, as Art and others have shown, but also the potential for other things, much bigger than mediators, to pass through. Here's an image that could have been taken from Dr. West's lab. It was not. It was from ours. This is ventilation-induced, ventilator-induced lung injury with an extravasation of a red cell into the alveolar space, and uncovering of collagen bundles, which can incite an inflammatory process in and of themselves. Are these experimental rabbits like us? And I think you have to say that there's a real question there. Larger lungs have larger alveoli with more collagen. But we did find in at least one patient, we only looked at one actually, that the epithelial tears did occur in this patient with ARDS, who was managed, of course, on the surgical service, not on our service, with high vascular pressures, high airway pressures, and you see the tears that may admit to bacteria and to gas. And there is some evidence, as Art alluded to earlier, that positive blood cultures are much more frequent when you use a high inflation pressure, low PEEP strategy than when you use a gentle strategy or a high inflation pressure, high PEEP strategy. It's not just the plateau, it's the plateau plus the PEEP that's important. This is from Avi Nahum's paper in 1997. Bacteremia on the vertical axis, hours after tracheal instillation of a marker bacterium dose. And of course, others have shown that gas can percolate through the lung tissue into the left atrium phasically with respiration. This is from Jean-Jacques Ruby's group. So, closing, key principles of lung protection. The risk for VILI is proportional to transalveolar pressure. Lung recruitment is essential to avoid VILI when high inflation pressures are used, especially in the early phase of management when the lung is recruitable. And this is another point of confusion. I think Bob Kazmarek said it nicely today. One of the most important things to look at is when are the patients studied? When are they vulnerable to VILI? They're probably most vulnerable early on, and we often make our mistakes early on. When tissue strain is high, modifiable cofactors may be important in VILI expression, including vascular pressure. My demand side economics, ventilation requirement. You've got to reduce ventilation requirements that will allow you to reduce ventilation pressures and cycling frequency. If you can reduce the cardiac output requirement, not fail to satisfy what they need, but reduce the requirement, you'll reduce the pulmonary blood flow, which will reduce the precapillary and postcapillary pressure gradient. With that, I'll end and take any comments that you may have. Thank you very much.
Thanks very much, John. Great talk. Comments, questions from the audience? Let me ask you, John, maybe to start while people get ready to ask a question. You talked about decreasing demands, etc. So how active are you in doing that? Like, what do you actually, can you give us examples of how you might do that?
Yeah, Art, the most important example, and I was talking with Fernando earlier about this, the most important example in the clinical setting is that when a patient is sick and getting sicker, don't let them labor to breathe on their own. If they labor to breathe on their own, there are lots of reasons to believe that their cardiac output's going to be higher, their demands are going to be higher, and that's when you need to take control. And I see over and over again it being recommended, you know, keep the patient spontaneously breathing. That's fine if they're not so sick. But it's not fine if the patient needs to be sedated, you need to keep up with acidosis. You need to take control. I have an editorial coming out on that to a nice paper that was done fairly soon. That's the best example I can give you. There are other things you can do, of course, liberal use of sedation, cooling even in some instances. Don't let fever go up and stay up and just observe it. You've got to bring it down to more reasonable levels. Metabolic requirements, reducing those would be the way to try to satisfy the demand side of the equation.
We have a microphone up. Oh, sorry, go ahead.
You referred to Dr. Marini, the study about fluid restrictive strategy with better outcomes in ARDS. When using an open lung approach with high PEEP, you're going to have a markedly higher central venous pressure, which is going to impede lung lymph flow and drainage of water out of the lung, which would, so it's kind of counterintuitive, those two studies, right? With the higher airway pressure, you're going to have a higher CVP and more lung water, and the study showing that less fluid, presumably with less lung water, is better.
Most of what I've said has had nothing to do, of course, with the quantity of liquid in the lung. I guess it's easy for me to say it needs to be studied more than it has to this point. I think in the setting of what we can do that is influencing our iatrogenic potential, the vascular side has been almost neglected, and it's an incredibly important feature. I would have to say that when doctors focus on maximizing cardiac output with pressors and lots of fluids, etc., they are testing the question as to whether or not they're contributing to ventilator-induced lung injury. I think that when you have high CVPs and you impede venous return, so long as the mean systemic pressure can keep up with that and blood flow is kept within acceptable limits, then it's certainly a defensible way to integrate all this information. I'm not sure I answered your question at all. Please elaborate if you're...
Maybe with the panel discussion. I guess the simple question is that we have a strategy that hasn't been studied in prospective randomized studies, and there's a potential mechanism how it may make things worse by having a high CVP impeding venous return, removal of water from the lung.
You're talking about the open lung strategy?
Yes.
Well, you know, when people have looked at the effects of PEEP on total lung water, they have found it to be pretty much a wash, that the fluid does redistribute differently. It doesn't necessarily go out of the lung or into the lung. And in fact, our studies would suggest that to the extent that the lung is kept drier, we'd probably be doing a beneficial thing there.
Those are, I think, older studies and not looking at pressures we're now talking about, where PEEPs of 25 with mean pressures significantly higher than that.
Yes, I think in the high PEEP area, we need much better information to really answer your question. It's a good one.
Yeah, and I think it's a good one for the panel discussion. I agree, because it's a question of we use aggressive recruitment maneuvers and very high PEEPs. You have to give extra fluid, and what's the trade-off there? And let's leave that for the panel. Okay. There's a question up here. Leave it for the panel. Leave everything for the panel. Okay. Any other? He changed his mind. Any other questions, Fernando?
Do you think that pulmonary hypoxic vasoconstriction can play a role in the vascular injury? for example, the constriction that may occur in attenuated lung regions, diverting the blood flow to other regions of the lung, increasing the perfusion pressure in those regions. If so, what would you suggest to minimize this additional type of injury?
It's unstudied, Fernando, but I can tell you that in unpublished work that John Hotchkiss has done with us, when we gave nitrates to try to undo vasoconstriction of all types, including hypoxic vasoconstriction, it intensified the injury. So it is the microvascular pressures that are important, and you're raising a good point. If you clamp down in the areas you should to preserve gas exchange, perhaps you are rerouting blood into areas that are stressed, and you may start to elicit trouble in those areas.
On that point on hypoxic pulmonary vasoconstriction, again, just looking at subpleural alveoli and alveolar capillaries, we did a study where our hypothesis was that in the unstable lung that there would actually be a distension of the vessels and preventing hypoxic pulmonary vasoconstriction. Therefore, there would be an increase in perfusion to exactly where you don't want it. And in fact, we actually saw a bigger squeeze, but the vessels apparently, the gross measurement of the vessels were still larger. So at least, and again, subpleural alveoli only, we demonstrated that it looks like if you have those unstable alveoli, they actually override hypoxic pulmonary vasoconstriction. So that's exactly what you wouldn't want.
Yeah, I think that a long time ago, Warren Zapal in his studies also would say something that would be confirmatory of what you say. When the vascular pressures are very high, hypoxic vasoconstriction may be overwhelmed, and it ceases to be a physiological condition, so that the hypoxic pulmonary vasoconstriction becomes a secondary player.
Great. Thank you very much, John.